be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. Thank you all for coming, everyone in the room, everyone joining from online, either from the YouTube channel and or Facebook Live. Welcome, welcome. We're happy to have you. We're also very happy to have Dr. Jonathan Goldman from UCLA up to talk to us today about precision medicine, which is perfect timing. I'm going to read a little bit from an article that I read today, which speaks to the importance of education around precision medicine from a patient perspective as well as a physician perspective. So we're really excited to have everyone tonight. Just a little bit of housekeeping before we start. If you have cell phones with you, please remember to put them on silent. Inevitably, some ones will go off, which is fine. Silence it when it happens, but we just like to remind everybody up front. And I also want to remind everyone online and everyone in the room, I see a new face or two here, that we do this for you. We bring this to you and these key opinion leaders in lung cancer here for you. So please don't hesitate to ask questions throughout. Do not be concerned that it is a question that might be too relevant to you, because you don't know that someone who's watching and or someone else in the room might have this very same question. They're just not answering it. Or somebody might come back and watch this post live and be really happy that you asked the question. So please, please, please don't hesitate. If you're online, Kim's monitoring the YouTube, and our very own David Leduc is monitoring the Facebook, so they will get your questions to us if you have questions online as well. Michelle is not here tonight, as some of you may see. She came down with what has been buzzing through this office for about the past month and a half. So I strongly recommended that she stay away. Barb's opening a bottle of champagne.
Right.
If anyone heard the pop,
but her son's getting married next week.
Yes, we're gonna do a toast to a wedding celebration that's coming up when it comes Barb's turn to talk. So we are going to start with our around the room like we usually do. Anyone online who wants to say hello, just please give a shout out to your moderator, and they will be sure to let us know that you're watching. Please don't hesitate to tell us where you're watching from, too. We always like to know where people are chiming in from. And with that, I am going to look at Sally, because she's directly to my left, and ask if you wouldn't mind starting. If you are new, please don't forget to grab your microphone so that the folks watching will be able to hear you.
And
Hi,
we also have quite a few people visiting the office from our East Coast office.
They're going to be doing introductions as well.
And you're going to get to meet some of our colleagues now that are on the other side of the U.S.
Yeah. Yep.
Hi, I'm Sally, and I'm 10 years cancer-free, thank God. I entered an early lung cancer study, the International Early Lung Cancer Assessment Program, and was found after 5 years that one of my nodules had grown, so I was able to have surgery. And I'm happy to say I'm now going to be working on 2 committees, other than something connected here, but 2 committees dealing with early detection of lung cancer, one at UCSF and one at Georgetown.
And what's that group that you're working with? What's the name of that group?
Here, this is something different. So tell a little bit about the UCSF, because that's the one I'm familiar with.
Okay,
That we've
well,
studied.
I'm sorry, my eye's watering from allergies. Danielle couldn't make a meeting and asked me to represent her at UCSF, and this was a good 5 years ago. And it was kind of interesting because I was the only layperson there, which was, I was in awe. And anyway, we had a couple of meetings, and then they didn't know if they had funding or so forth. So that got put by the wayside until they found funding. And I had been in touch with the gal a couple of years ago. They were still looking for funding. And they evidently have it now. I'm going to the first meeting tomorrow up at UCSF. And it's going to be working on early detection. And the other one that's through Georgetown right now, the gal was originally part of this group and moved to Georgetown and is doing something else with
And
it.
part of it, Sally, is to try to work on driving people to screening, right? I mean, that's a huge part of it, how to get those numbers up.
And deciding whether people are eligible really to do the screening.
Yeah. Well, thanks for helping.
My pleasure.
Hi, Barb.
Hi there. So first of all, to our son who's getting married on Sunday in Portland, Dave will be making it to the wedding.
Okay.
So we're all happy about that.
Okay.
And as part of their registry, this will probably make me cry, they registered at Crate and Barrel and Amazon, and then they registered at the Bonnie and Dario Foundation. And they've already raised $1,150
how
on their wedding
cute.
registry for the foundation.
That's so cute. Tell him thank you. That's darling.
Anyway, I am here tonight, as always, sort of as the spokesperson for my husband, Dave, who was diagnosed in March of 2017 with stage 4 non-small cell lung cancer, EGFR positive. He had cancer had spread to his brain and his lymph node, one of his lymph nodes. He had significant pleural effusion as well, fluid in the lining around the lungs. So he had almost immediately stereotactic radiosurgery, SRS, to his brain mets. He was put on Tarceva, and things were pretty well controlled for about 18, 20 months. And after that point, things started to go awry. The cancer started spreading. He was put on Tagrisso instead. And he did not respond. The truth was he wasn't on it long enough to really know for sure that it wasn't working, but the cancer was on a rampage. It spread to his liver, many spots in his bones, additional lymph nodes, and he was in major pain. So they basically pulled him off Tagrisso, started him on chemo. This was this January. The pleural effusion, meanwhile, had also gone crazy. He had to be drained, I think, 4 times in like 3 months. And so he started on carbo and Alimta. He had 4 treatments of that. He's now had his first treatment of Alimta only, and will have his next treatment after the wedding, which we've put the next scan off till after the wedding because we just thought it's better to just wait till after that's done. So that's what's going on. We do know that after the first couple of rounds of chemo, they did a scan again, and most of the bone mets were either gone or reduced in half. Other stuff too, the spot on the liver was gone. So the chemo definitely seemed to be working, which we were really thrilled about that. It's, of course, not a picnic, as many of you know, and mostly fatigue for him. Also immunity issues, which is why he's definitely not here tonight, and will be wearing a mask on the plane tomorrow. His blood cell count numbers are pretty low, but all in all, we're glad he's still hanging in there, and we'll be at his son's wedding on Sunday.
I'm assuming he's watching as well.
Raptors are on too, right? So
All right. Well, hi, Dave, if you're watching. If not,
Hi, Dave.
Hi, Dave.
Hi, I'm Larry. I was diagnosed stage 4 non-small cell adenocarcinoma in January of 2013. I did a year of chemo. Like Dave, I did 4 rounds of Alimta and carboplatin, and then I did maintenance for the rest of the year, 2013. 2014, I went on a chemo holiday, and I was lucky enough not to progress for a whole year. January of 2015, I progressed, and I'd had genomic testing done, so we knew I had an EGFR mutation, so I started on Tarceva, and I was on Tarceva for 20 months, progressed again, and we knew I had a T790M mutation, so I started on Tagrisso, and I've been on it for 2.5 years. I had clean scans earlier this month, and I started on the same clinical research project as Joan, and they took my blood along with at the same time as I had the scans. So in a few months, we'll see what that says.
Thanks, Larry.
Hi there, my name is Jennifer. I was diagnosed last August with stage 4 lung cancer with mets to the brain. They started me off, I actually have EGFR positive with exon 19 and PD-L1. So I was taking Keytruda for the PD-L1 and then cisplatin and ellipta, I never say that correctly. And now I'm on maintenance with just the ellipta and the Keytruda. And so far, so good. I have scans coming up, so of course I'm concerned about that, but as we all go through that same process. But
Do you know what your percentage of PD-L1 was?
31 to 40.
Okay, that's pretty good.
Yeah.
No?
Yeah. So anyway,
And the scan, you're not alone in that scanxiety thing, as
Yeah.
people will tell you in the
Yeah.
room.
Oh,
Scans
yeah.
are coming up, everybody.
yeah, and every little ache and pain, you think, okay, it's changing. But I've been lucky enough to really be stable in all my scans. So,
great.
but you still worry, even if you have that.
course.
So
Sure.
It's just, I guess,
Sure.
the way it is.
Thanks, Jennifer.
Hi, I'm Rick. I'm here with Tina, my wife, and I apologize for everybody for not being here last month.
We were so mad.
Demerit. Demerit. Yeah. You quit having fun. You stop it.
I'm Tina, and I was diagnosed in November of 2010. So in 2 days, it will be 8.5 years.
Yeah. Okay, that's a clap. That's a clap.
Yeah.
And she's jazzercised her way through the last 8.5 years.
Right.
Like, literally.
Literally, yeah.
Yeah.
Right
Yeah.
through chemo and,
Yeah.
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 So I was staged at 3B with positive for EGFR, but I did do chemo and radiation, and then after that my scans were NED, and my doctor decided that, he said, let's just try it for a year. We'll just put you back on Tarceva because we know that it works for you, and we'll just do it for a year and see how it goes. And then another year, well, it's going good. Let's just try it another year. So here I am. Let's see. I guess that's more than 7 years on Tarceva. So, and so far my scans have been NED. So, I'm very grateful.
Thanks, Tina.
Good evening. I am Ken Adler. I am a survivor of prostate cancer. This past March marks my 10 years of post-prostatectomy survivorhood. One of the pillars of my my survivorhood and thriverhood has been exercise. And shortly after my recovery, I entered into a program known as Living Strong, Living Well. And as I speak, I am now a trainer for cancer patients referred to us through the network of Stanford. I have some literature here regarding the Living Strong, Living Well program. If there's opportunity, I'll elaborate. But briefly put, our mission is to work with cancer-challenged people, regardless of the type of cancer, to help them build strength, cardio conditioning, balance, and I like to call it esprit de corps as a survivor. And I'm happy to be working both with the Sequoia YMCA and the Palo Alto Y facilitating this program. And I would say Most of the people that we have in training for the 12 weeks are still going through treatment. So you're all familiar with the challenges of treatment and its various stages. And most of our people I would consider very brave and undaunted, given the day-to-day challenges that they have to contend with as far as the effects of chemo. So we have an abundance of literature. We'll talk further.
Thanks, Ken.
I'm Pat Pritchard, and I was diagnosed in November with lung cancer and opted to continue my journey to Paris with friends on a riverboat and London, and just a super fun trip, and come back and then have the scans. So I think it's BRAF positive on one side and negative on the other. In March, after multiple scans and biopsies, I received radiation, and now I figure I'm on hold. And I'm not going to stand still while I'm on hold. So I've been doing Ken's program and really enjoying it. And some days are hard, and some days are, I got to get my energy up because it may not be there tomorrow. So I am trucking on through. And I will find out at the end of July where I am, because it's all unknown for now. So might as well enjoy what I have.
And for anyone in the room that's new or newly diagnosed, when people say NED, what that means is no evidence of disease. You have two.
Yeah, you guys
each
have that
one.
yellow
Yeah,
one.
right.
I'm Ron, and here's Joanne, and I carry her water.
I'm Joanne Berridge, and I was diagnosed after a year of misdiagnoses in September of 2016. I was adenocarcinoma, non-small cell lung cancer, EGFR positive, exon 19 deletion. And as soon as that was known, which I don't know, took a couple of weeks, I was put on Tarceva, which had a very fast reaction. I was rid of my metastasis. I was stage 4. I have to back up. And my metastases were bone and one adrenal gland. And after a couple of months on the Tarceva, the adrenal gland was gone, the bones were gone. There was still some metabolic activity in the middle lobe of my right lung, which was where the original tumor was. And then that all stayed that way. Actually, it even got smaller, the original tumor, at the second scan at 4, 5, 6 months out. And then everything stayed stable for 2 years. Just before the end of the 2 years, I became part of the Signatera blood biopsy research at Natera, and which checks for progression is what it's for, and it identifies circulating tumor DNA. And a blood test at about the 2-year mark showed that my tumor DNA, that it had started to creep up. So I immediately was done a Guardant test by Dr. Blakely at UCSF, and that showed the T79M, and so that was Tagrisso immediately. It might have been Tagrisso anyway, because in that interim, it had been approved as first line, and I was having some pretty severe reactions, the scabbing on my head and losing my hair in an abnormal fashion.
Beautifully, though.
He was about to change me to the Tagrisso anyway, but anyway, the T790M did that, and I have been on that for 9 months now, and hoping to catch Larry at 2.5 years and beyond. And also, I need to point out to Sally, because we've had this jousting about who's the oldest. I will be 80 next Tuesday.
Okay.
Happy birthday.
That's awesome.
One of the things I want to point out about Joanne and all of her comments is the mouthful of words that she used, and particularly for some people online. I know that the folks in this room, you guys tend to come month after month, and you're well above the sort of educated level of the average patient. So I appreciate you being proactive and knowing exactly what is going on with your body and sharing it with the group.
That's what they told me at Natera too when I went into the study. I told them my history and I knew this and I knew that. And just, this is unusual.
Yeah.
They knew where it came from.
Yeah, it is
It
unusual.
comes from here.
Yeah, it is. I don't know who's. There we go. Thanks, Bridget.
Hi, my name is Teresa, and I was diagnosed in June of 2017. This is my second visit, but I watch all the time on YouTube. And so I was diagnosed with allergies for years, was taking Claritin, and then they thought I had GERD, and then I finally started to lose weight, and my cough never stopped. And then they did a X-ray, and they found a huge mass in my right lung, and then it turned out I went in right away for a CT or a PET scan, and they found a 16-centimeter tumor in my right lung, and I went in. So I was fortunate to also be treated by Dr. Jablins, and I'm so sorry I wasn't here when he was here last month. Yes.
Yeah.
And my oncologist is also Dr. Blakely, and so they did a needle biopsy and a blood biopsy, and they found MET exon 14, and I wanted to ask maybe the doctor too. So the SUV factor, I'm not quite sure it's a standard uptake value, right? Yeah. Was 26, and I don't know if that's significant, but it was.
So it's the absolute number isn't, but that is a high number. And that shows a high metabolic activity of the cancer cells at that time. That was at the beginning.
That was at the beginning. So then I had MET amplification as well, and then I was put directly onto crizotinib, and immediately I felt better. It shrunk to where it was an unresectable tumor, and then it shrunk to a point where I went from stage 4 to stage 3A, and then Dr. Jablins did an excellent pneumonectomy. And I didn't suffer any pain from that. I went back to work in 4 weeks, and so, but I wanted the surgery as well. I kind of had to insist, and so did the tumor board wanted me to insist, and so they had written an article, so I had a pathologic complete response on crizotinib with no chemotherapy and no radiation, just the crizotinib. I just stopped, so I've been on it for about 2 years, and I just stopped. Yesterday was my first day off of crizotinib, and I'm a little bit worried about that. But, I've been feeling really great, went right back to work, and so I'm so grateful, and I love watching this because people like Bonnie who are long-term survivors, that does give us a lot of hope. And so I hope to be one, and I hope everyone else too will be long-term survivors.
Thank you for sharing your story, Teresa.
That's awesome.
Hi, I'm Rick. I was diagnosed in February of 2015 with stage 4 adenocarcinoma. I'm being treated at Kaiser in Santa Clara. I didn't have any of the genetic mutations, so I got to go straight into the old-fashioned chemotherapy. I did the standard carboplatin and Alimta for 4 cycles, and then Alimta only for a while until the tumor on my adrenal gland progressed. At that point, that was my only active tumor, so they were able to surgically remove it. And then I went on to Taxotere for 6 more cycles. But in February of 2016, just a year afterwards, I got my first clean scan, and I've been NED for 3+ years now. So I've been, during the whole thing, I scaled back work all the way down to going on to disability and then retiring altogether. Fill my days with volunteering. But a year after my chemo, or 6 months after my chemo, they took me off my blood thinner, Lovenox. And 6 months after that, I ended up getting this DVT, blood clot in my thigh that I had to take care of. And they ended up putting a stent in my iliac vein. And while I was in there, I had some other issues that I ended up having to take care of. But had a scan last February. I'm going on to alternate CT scans and PET scans. But really enjoy, coming here to the support group and learning so much and always having, more information that I can ask my oncologist about and get those
In some cases, more than they know.
So.
Thanks, Rick.
Hi, my name is Wayne. I'm a caretaker for my wife, Rebecca, who's not here tonight. She's at home dealing with a case of pancolitis, which was diagnosed yesterday. She was diagnosed November 2017, stage 3B adenocarcinoma, but she's currently now at stage 4. She has a KRAS G12D mutation, no PD-L1. She started off with chemoradiation to her primary tumor and then consolidated to durvalumab per the Pacific trial. It was during that time where the disease had progressed and she developed 6 brain mets, which were taken care of by CyberKnife, and her brains look great right now. In August last year, she started 5 cycles of carboplatin along with Alimta and Avastin. And now she's currently on a maintenance of the Avastin and the Alimta only, and she's considered stable. So everything looks pretty good so far.
That's great.
Thanks, Wayne. Is she watching?
She may be watching. It depends how
Hey,
she
Rebecca. She's all cuddled up with the puppy, I'm sure.
Yeah, exactly.
2 dogs, actually.
Oh, you have another one at home?
Yeah, he's too big to be brought there.
Hi, Fred.
Hello. My name is Fred Palmer. I was diagnosed with non-small cell lung cancer in October of 2013. I was on immunotherapy up to September of 2018. I'm currently not getting any treatment at all, but I'm stable. And I'm on the same Signatera clinical trial as the other 2 in this room.
I bet they're very happy they came here that night because they left with they practically accrued their trial.
That's great.
Hi, my name is Karen, and I am actually an 11-year survivor. My finding was accidental almost 11 and a half years ago, and I was staged to 1B pretty quickly, so I immediately had surgery and then had chemo after that, after like a 3-hour discussion with Fred Marcus, as Bonnie knows. He was so awesome, and we could have gone either way, but we decided we needed this insurance policy. But at this point, I am just happy to be here. This organization is just fabulous, and now having the East Coast with the West Coast, it's going to be even greater, and I just look forward to doing all that I can to help everybody work on early detection and do whatever needs to be done. Thank you.
Hi, good evening. My name is Evangeline, and I was diagnosed non-small cell lung cancer adenocarcinoma on March of 2017. And after a month after I was scheduled for a surgery, because first they thought I have stage 1, which is only contained on my upper left lobe of my lung. But after the PET scan, they saw a cancerous lymph node, so they decided to have my head scanned. So after the MRI, it was found out that it metastasized to my right brain and another tumor on the left bone of my skull. And so officially I was categorized stage 4 on April of 2017. So they immediately I had a CyberKnife radiation on May of 2017, and I was put on Tarceva. I was diagnosed with EGFR positive. So from I had Tarceva. I started May of 2017. After 11 months, the tumor on my upper left lobe shrunk by 1 centimeter. And then my case was dormant for 17 months. And December of last year, after the MRI and CAT scan, it found out that my tumor increased in size. So my oncologist says the Tarceva is no longer working. So I went through blood tests again with the T790M. First it failed, the second one is negative, but I debated that I don't want the 6-cycle chemo. So my doctor ordered a biopsy, a CT scan needle biopsy. So I qualified for the EGFR. I was EGFR positive, but he said it's only 7%. But he said, let's take a shot. So he put me on Tagrisso. So I started Tagrisso on April 27th, just recently. And there's a roller coaster effect, but I'll be okay. With this organization, I know I'll have hope and I'll be okay. Thank you.
My name is Ken, and I'm a caregiver for my mom, and she was diagnosed March 2017, and she had kind of nodules on both sides, and the biopsy came out L858R, and then she got started on actually dacomitinib, and she saw the oncologist today, and there's just a question of one spot getting a little bit larger on the opposite side, so they're going to get a Guardant test.
Thanks, Ken.
Great news.
Hi, good evening, everybody. My name is Emily, and I'm the Chief Program Officer for GoTo Foundation. I'm actually based in our East Coast office in Washington, D.C., but I'm very happy to be here all week with all of you and my colleagues. I have also been personally impacted by the disease, so this is not just a job for me. This is very personal. I've had 2 parents with lung cancer, but very proud to say that my mom is a 2-time, 20-year survivor and a 1-lung warrior. So thank you all for sharing your stories.
Thanks, Em.
Good evening, everyone. My name is Angela Criswell, and I am the Associate Director for Quality Screening and Program Initiatives with GoTo Foundation for Lung Cancer. I'm originally based out of our East Coast office. However, I'm actually located in Kentucky, which leads the nation, unfortunately, in lung cancer, the rates of lung cancer incidence and mortality. And my role is primarily to lead our network of more than 680 screening centers of excellence across the country. I'm very glad to be here with you all this evening.
Thanks, Angela.
Good evening, and for the East Coast people, evening, because I just got here today, and so getting adjusted to the time difference. I'm on the patient services team, and I'm so thrilled to be here, seeing everyone in the room, and hopefully some people that I know are online. So I answer the helpline, which appeared at the beginning of the program. So if you ever need anything and you want to call and ask questions, I will. If I don't know the answer, I know who to connect you with. But I also manage our Phone Buddy program. So that is a peer-to-peer mentor program where I match people for support. Also our Guides program. So if you have any questions or want to approach me afterwards, please do. I'd love to meet all of you. I'm happy to be here.
Thanks, Miranda. Yeah, Leah's fine. They know who Leah is. So just we can talk a little bit more about the Lung Buddy program, but I know patients ask all the time, and then we'll jump into who this lady is before we start moving through the program. But the Lung Buddy program is a really cool way to get involved for those who want to. It's a mentorship program for just sort of an ease of a really quick explanation, where some patients who are sort of further down this path, post-diagnosis, who become more educated through programs like this, and of course other avenues across the way, become mentors, particularly for some of those who are either early, in their diagnosis process or maybe having some trouble coping and so on and so forth. So it's a really great program that Miranda spearheads from the East Coast. So if anybody's interested, please take advantage of her while she's here tonight. Hi.
Hi.
Who are you?
And eventually there'll be one number that you call for GoTo Foundation.
There still is. There already is.
And whoever you ask for, whether they're on the East Coast or the West Coast, the call will be transferred there. So it'll be really seamless.
Yeah.
I'm Bonnie. I pretty much know, who everybody is here, and everybody knows my story. The good news is 15-year lung cancer survivor, stage 3B. Had it all and had a huge surgery with Dr. Jablon's. We were doing a little name throwing out tonight for him. He loves it. He loves hearing his name on TV. And somewhere along the way, I just really got very angry about the research funding for lung cancer and the lack of multidisciplinary care for lung cancer patients, in the community and various other things, and thought I'd start this little foundation and raise a little bit of money for research. And that was 13 years ago, and here we are today doing, merging with other companies on the East Coast. I mean, that wasn't in my little dream. Now it's a big dream, and it's one we're going to realize together. I'm really confident that this merger is, an amazing opportunity for all of us. So exciting times.
She's being very modest, and I will just kind of throw out. So for some of you may have tuned in last week. Michelle and I and Emily and Lanny, who is one of my East Coast colleagues, we're out in Florida for one of our regional living rooms, and Dr. Reyes and his team from Memorial Cancer Institute were on the panel, and part of the discussion turned to patients saying, what can we do? Because they feel like they can't do anything, and Dr. Reyes, I don't know if he turned in or not, but anyway, he said, what do you mean, what can you do? He said, Bonnie was one patient. Look what she did. That's what he said. So he gave you a huge compliment.
That's great.
And it was
I
really
love
cute.
him. I sent him a patient today from Mexico City.
Oh, great.
Who was sending me all of her...
Hopefully they come to our living room. We're doing there in October.
Yes. Well, I will.
Yeah.
She was sending, God bless her, she was sending me all her scans, and they were all in Spanish. So I picked up the phone and I called Louis and I said, I really need your help. So he read them all, and he called her there, and it worked out well. I delegated.
So for those of you who may not know me, and I know most everybody in the room does, unless of course you're new and we haven't had a chance to meet, I'm Danielle. And I oversee patient services for GoTo Foundation. I get to work with all these amazing people, some of who you've met before, some of who you just met tonight, and some who hopefully you will be able to meet as we're traveling back and forth between offices. I'm also Bonnie's daughter, one of them.
The oldest.
The oldest.
The youngest is over there.
Yeah, the youngest is over there. Most people know Andrea too. And I've been doing this. The foundation started in 2006. You were diagnosed 2003. So I've been in lung cancer, walking, talking, living, breathing it since since she was diagnosed in 2003, 4. So it is absolutely my passion, and I love what I do, and I love getting to see all of you, and I love getting to meet people on the road. So thank you all for letting me do this. Kim, does anybody want to introduce themselves online before I turn it over to Dr. Goldman?
Not introduced, but Ron Fong just sent a
Hello,
message.
Ron Fong.
It's very active online, but he sent a message that he went to the DC International Lung Cancer Survivor Conference and it went well.
Okay,
and he got to visit the East Coast office and had a great time.
That's great.
That's
and
great.
he said, tell everyone hello.
That's great. Thanks, Kim. So normally, or historically, as some of you may know, I read this big bio of whoever our speaker may be, and it seems super impersonal. I'm in my paper because I can't possibly remember it. And probably about 4, 5, 6 months ago, I started asking our speakers to introduce themselves. It feels more personal. So I'm gonna turn it over to Dr. Goldman to introduce himself and tell us why he chose lung cancer as an area of specialty.
Great. Thank you very much. My name is Jonathan Goldman. I'm at UCLA. I direct the clinical trials and thoracic oncology program. I also do, I'm the associate director of the drug development program. And because lung cancer has been such a hot area of research, because so many drugs have been developed in lung cancer, it has been a remarkable place to have a career recently. I came, I think, 2 years ago or so, and I recognize some of the people, and it's really a tremendous thing that you've put together, and I'm just learning about the Go-To Foundation, but I am certainly reminded of why I do this, and it's wonderful to get to see everyone not rushed in the, not in a clinic, but sitting down together and spending a little more time. I trained here. I was at UCSF and Stanford, and so it's nice to come back to this area, which I definitely remember very fondly. When I decided to study cancer and lung cancer in particular, and you can see from what people said, this brings you very quickly face to face with very intense parts of life, and that was something that I felt able to be part of, and it was very meaningful. It immediately became very meaningful to me. Lung cancer, over a relatively short amount of time, went from a disease where many patients, doctors, family members, legislators were very, what we'd say, nihilistic about, that therapy didn't make a difference, that it wasn't clear that treatment was worth side effects, and that it sometimes wasn't even worth seeing an oncologist or discussing treatment options. And when you look at it that way, what a remarkable change has happened. It didn't used to be that you could talk in a room with people that were, 3, 5, 6-year survivors, let alone 10 plus years. That's not that obviously to say we still have a lot of work to do. I think we do have what we heard some of these sequences of responses and resistance, and response and resistance with new and better drugs. But we certainly have our eye on the possibility of can we do even better than that? There are a lot of different ways that we've learned to treat lung cancer. The standard older way is chemotherapy. And as we heard from some people, there really is still a role for chemotherapy. And actually, the only downside of all the new drugs that we have is sometimes people get so scared of chemotherapy that there is still a role for it. And sometimes it's actually clearly the best option. Mm-hmm. And in fact, our lung cancer chemotherapy, very thankfully, is effective for most patients and tolerable for most patients. So that is a good thing compared to some other cancer programs. We also have added to that immune therapy just in the last few years. And often immune therapy can be added to chemotherapy. We do talk about PD-L1, which was brought up as a marker, a predictor of benefit from immune therapy. But even aside from that, there are benefits to immune therapy. You can think of that as a targeted therapy. If a patient has high PD-L1, that directs them to an immunotherapy course. But what I mostly am going to talk about in targeted therapy is another type of treatment that is based on finding a mutation and treating that mutation. And maybe a third, if not more, of the patients here described EGFR mutations. And that's definitely the most common of these treatable mutations. It's about 10, 12% in this country. In Asia, interestingly, not entirely for clear reasons, is much more common, 30% or so. These mutations are more common in never smokers or minimal smokers. And in that situation, it can be 30 or 50% of the patients. And I think that's really what you might call the poster child of targeted therapy in lung cancer, really where we first saw some of these early drugs, Aresa or gefitinib, some might remember. And
It
then
was Tarceva.
And then Tarceva. Yeah, so they actually were used because EGFR was thought to be important in general. And in some patients, there was very little benefit, but in some patients, dramatic benefit. A patient with cancer throughout both lungs, they would be cleared. And it wasn't immediately obvious why. And then wonderful research identified that those tumors had a mutation in this gene called EGFR that was causing a growth protein that should be turned on and off at the right time to always be in an on position and cause constant cell growth, out of control, not functioning well with the rest of the body. In a pill with a small molecule in it that would block that mutation, turned that off. And it really opened up a world of targeted therapy in general, but especially for lung cancer. And increasingly over the years, about 15, 16 years now, we've been identifying new mutations. We think about the pie, pie chart of cancer patients, and we get more slices of the pie as we understand some of these mutations. We're a little bit better than 60% at finding what we call driving mutations in the most common kinds of lung cancer. And for many of those mutations, not all of them, but many of them, we're getting better and better drugs. So we talked about Tarceva, and now we have Tagrisso. For the next most common, called ALK, we started out with crizotinib, and now we have several new drugs. We've actually already on to fourth generation drugs, and what do we mean by these new drugs? What's remarkable is that these drugs are more effective, less side effects, and excitingly better and better at treating some of the most difficult situations, such as cancer that's gone to the brain. So now instead of going to surgery or going to radiation, we're often seeing, can we treat with a pill? And so that can be quite remarkable, avoiding some of those side effects or at least holding them off. Again, we still have this problem of drugs working for a while and then needing to look at new drugs, but some of these newer drugs are not working 10 months, but working 18 or 36 months, depending on the situation. So that's the way we've seen a lot of progress, by building new understandings. We heard about MET mutations. MET mutations were only described a few years ago. We actually reported the first time that crizotinib was used. And it was a patient who had not done well on 3 different kinds of chemotherapy. And she really was unsure whether to go on more treatment. And what we did was, at that point, not yet standard or not yet commonly done, but did an extensive mutation screen to look for, are there some mutations beyond the ones that we know about? And we found this MET mutation. At that point, very little was known, but we decided to try a MET inhibitor, crizotinib, and just as you're describing, really a dramatic response. Those stories don't happen all the time, but I think one of the ways I like to think about this is just, can we provide more and more options? A patient may have to try 2 or 3 possibilities, but can we get to something that may work particularly well? Just today I saw a patient who, actually going on 6 years ago with EGFR mutation, started growing very, very quickly. Probably in retrospect, she had something called a small cell transformation. We radiated that area, put her back on Tarceva, and then somewhat beyond our wildest, or absolutely beyond our wildest expectations, that has kept things under control for these many years. And you don't always know which of these different options is going to be perhaps the silver bullet for a patient. But by having more and more of them and learning increasingly, what are our best ways to put this together? We hope to have these incremental improvements, and then occasionally we would like to have revolutionary improvements. There was a few other things I wanted to make sure that I focus on. One of them was just the importance of the mutation testing, particularly MET, because MET is a difficult one to test for, MET mutations. But in general, we heard several patients that were treated for a while before an EGFR mutation was found. We would like to have as much testing, as much identifying of mutations as early as possible. And that's one of the ways that patients really can improve their care, is by talking to their doctors about, have we done the testing that we need to do? Are there other things that we should consider now or in the future? There are so many different ways to test now. There's not a single solution for every patient, but we do have these broad tests that can test not just 3 to 5 genes, but hundreds of genes. And it may be that that's the direction that we're all moving. But it's certainly appropriate to ask those questions. One of the things that's made the biggest difference for me as a doctor is that we can now test a lot of these mutations in the blood, and we get the results in a week. It's just remarkable what that can mean for a patient that's either just had their diagnosis or has gotten very sick. And those are things that really we didn't see. We didn't even when that became available, we didn't realize what a revolution it was until it developed to be part of our practice. Yes.
At some point, and you don't have to do it now because maybe you need to do a little bit more to lead into it, but I'd like you to talk to patients tonight as well, because we're talking about precision medicine.
Yeah.
And, one's exon 14, one's exon 19, and then we got exon 20, and how important those submarkers are becoming.
So before we jump into that, because I do want to get into some of the specifics, I want to kind of step back even further. So for the folks online who might be really early in the diagnostic process, or those who might come back and watch later are in that early sort of space, can we step even back to the diagnosis and sort of what good looks like through that whole diagnostic process and biopsying and testing for these mutations that you're talking about? What is a mutation? Maybe even why do they happen, and why it's important to know what someone's mutation might be before determining a treatment.
Yeah. Well, I really love getting these questions, and it's always clear when a patient comes from you who really understands their cancer, and the stories that we heard are, I think, a great way to be a partner in the process, and to not feel pushed along by the process, but to be an active participant in it. So lung cancer particularly, many patients here talked about thinking they had asthma or allergies or something. Sometimes lung cancer diagnoses do take longer than you would want. And so at some point, a chest X-ray or a CT scan or a new symptom shows that there's a mass in the lung. A very important part of the next step is we need a biopsy to prove what it is, and we need staging scans to see throughout the body where is the cancer at that point. The biopsies can either be done with a CT scan and a needle, or sometimes there are small surgeries that are done to get at lymph nodes, for example, or a bronchoscopy, where a lung doctor, a pulmonologist, will go down the lungs with a scope and grab a piece of the cancer. Then a pathologist will look at it under the microscope and say, these cells are clearly abnormal. They're not behaving the way they're supposed to be. They're not following the lines of usual cells. And in this case, they look like lung cancer cells. There are proteins that we can find on the surface that identify a cancer cell as a lung cancer cell. We might be able to say this is the most common kind, called adenocarcinoma, or maybe it's squamous cell. We didn't hear that much about another group called small cell lung cancer, but those would all be identifiable by the pathologist. The pathologist will also take, or hope to take, some of that biopsy and do what's called mutation testing. A lot of times that is through sequencing, meaning that you look at your DNA, or you look at the patient's DNA. DNA is on a strand, one letter after another, and they will use these laboratory techniques to rebuild that strand in a way that you can tell what was there. And we know what the normal is, and there are, in many ways, predictable ways that could become abnormal or mutated in a way that would promote cancer. It's a lot of words. It probably wouldn't hurt for me to say it again in a different way. But the DNA determines proteins in your body that create the normal function. And a mutation in the gene leads to a mutation in the protein that can turn the on and off switches of normal physiology, normal biology, to become wrong, to become dangerous, and sometimes that leads to cancer. We all, through our lifetimes, get mutations in our cells, and a lot of those mutations don't do anything. There are whole regions of our DNA that are not important, that just have like the detritus of evolution, but some of them come up in very important areas. The reason why there are certain common cancers, like common skin cancers or lung cancer in smokers, is that there are some exposures that cause extra mutations, like tobacco or the sun, the UV light and sun. And that can cause hundreds or thousands of mutations. And just, you can imagine by chance, if you're getting thousands of mutations, one of those or a group of those could lead to enough abnormality that cell becomes cancerous. Most of the time, though, across cancer, we don't know why those mutations happen. It's just the cancer, the growth process, the cell growth process is so complicated and happens so many times that the chance of having an error becomes real over 50, 60, 80 years of life. Sometimes that is reassuring to patients. It's not that they did anything wrong, but that this can just happen. Sometimes it's also hard to know that some of this didn't happen for any reason. I think there are a lot of emotions that these events bring up. But what we do know is that this is an important part of the cancer process. I said that some of these mutations happen more commonly in Asian populations, and frankly, we don't know why. There are still some things that are yet to be understood. But through the late 1900s, people started to understand that an accumulation of mutations could cause cancer. And then really through the 1990s and this century, we really became focused on what are the most important ones of those mutations. What are the ones that are driving the cancer, be it breast cancer or be it stomach cancer or lung cancer. And really, lung cancer in a lot of ways has led the charge towards this type of treatment. I'd been using targeted treatment, but we can also use the word precision medicine, meaning that it's the right drug to the patient. And the sooner the better, and the better the drug, the better. But the basic concept of identifying what made this cancer cancerous ends up being very powerful in a lot of situations.
So we get the biopsy, right? And quite often, as some of you know, and as one of my pet peeves, and I complain about it a lot, is the percentage of patients that actually go on to get this type of profiling, of the molecular profiling, right? And it's one of the things, and I'll get to it a little bit later, but it's about the article that I was reading today. And in academic centers where Dr. Goldman works, it's happening with the appropriate patients, right? Where it's not happening, with the appropriate patients is in the community setting, right? Necessarily, not all community settings, but 80% of patients, as you guys know, I say it over and over and over, it sounds like a broken record to those of you who show up every month, but 80% of the patients are seen in the community setting. And a lot of a huge percentage of those patients are seen in very rural areas, right, where there's a general oncologist who's treating whatever walks in the door. So, in my opinion, it's an unfair expectation that they would know everything there is to know, especially with how quickly things are happening today in cancer in general, lung cancer for sure, but in cancer in general, with all this molecular profiling. And then, oh, we found an EGFR mutation. Well, now what do I do with that, right? Which is what happens a lot, which again is why it's so important for GoTo to be able to provide education services like this to you all and those watching, and to have these guys come in and talk. So why is it important that we find out what the molecular makeup is of each individual patient? What happens once we know that?
So there are some still legitimate questions about should we be testing everyone, and at what point. So it part of what makes it difficult is it's hard to make an across-the-board recommendation. But we do know that most lung cancer patients are diagnosed at stage 4. And most are adenocarcinoma, the plurality are adenocarcinoma. And in that situation, it's become clear that we do need at least the mutations tested that we have an approved drug for. We need those mutations tested. And I actually think that things are getting better faster and faster. But I don't know the whole country. Right. But I do think that as we get drugs to treat patients and as doctors, it's also a joy for the doctors to be able to treat someone successfully with one of these new medications. As that happens, I do think that people are doing more and more testing.
I think that they are. I just want to give a quick example, and I don't mean to interrupt you, but it just happened today with a caregiver for a patient whose mother was EGFR positive. She progressed, and they were going to put her straight on a chemotherapy, right? So, of course, the recommendation is please go back and talk to your doctor about looking for T790M. They can find it in the blood, blah, blah, blah. The caregiver goes back, speaks to the physician, and the physician says, and this is in a fairly rural part of California, actually. How did you find that out? Where did you find that out? How can I get this information? The physician is asking the caregiver. So it's a real problem in a lot of places. It's not the first time that I've heard about it, right? And it just kind of show not only the diversity within the patient population, but within the clinicians that are treating the patients as well. Yeah. Right?
Well, and it's a top-down, bottom-up program.
Sure.
And the most important person in that top-down, bottom-up is the patient. You have to find out what is, the right program for yourself, and you have to be able to have a discussion with your physician, with each other, to come to terms with an agreement and say, okay, we both agree. This is the road we're going to go down.
And not to send us down a rabbit hole, but that's
right. Not a rabbit hole.
Even educating patients can be a huge part of the problem when you look at health literacy in this country, right? And you look at, Angela talked about Kentucky, and not to pick on Kentucky, but it's got a high propensity for lung cancer, and it also has a very high population of people who don't have the benefit of college educations and understanding, right? Even what we're talking about here tonight.
Well, and they don't have insurance and 1,000 other things.
Like I said, no, I don't want to do a rabbit hole, but yeah, it's a problem, for sure.
But the information is there much more than it was when I was diagnosed 15 years ago. If you even thought about getting on the internet and typing in lung cancer, it was just the worst day of your life, because there wasn't anything good to hear then. And
I'm going to just go to home for 1 second, and then we're going to jump back on the actual topic for tonight. But between our screening centers of excellence and our care continuum centers of excellence, we are able, and NCI designated centers and different things like that, we are able within fairly close proximity to help guide people to the support that they need, to the care that they deserve that are very high qualities, right, from at least around the country and around the world, but for a huge part of this country. So I wanted to make sure to do that little go-to commercial in the middle. In the middle, so we
There is something good about getting a second opinion.
Yeah.
Also,
Absolutely.
I think it's often true that a second opinion will be different in some ways, and so that adds its own challenges to weigh those different opinions. But it does give you a little assurance that you're not missing a big category of possibilities.
And it's always, I find it always so interesting that people will spend more time buying a car, finding out, all of the accessories and all of what's under the hood, and mostly men, I'm sorry. And when it comes to their own health, they don't do the same research.
Yeah, there are so many emotions and feeling overwhelmed that can come with this, which is which you might also feel getting a car, but it's a lot to deal with all at the same time, and perhaps when you don't feel well at that same time.
Yeah.
But I do think at some point a second opinion can be very helpful, and you want to feel a connection with your doctor. You want to feel that they're hearing you, that they can explain things and why they're doing something, and that you have the room to ask questions.
And I want to have it's never too late conversation to do just that with second opinions. But I want to jump back into. So we've had the biopsy.
Yeah.
You're in a center like UCLA with a great doctor like Jonathan, and all the right things are happening. The biopsy. What are we looking for in the biopsy?
Sure.
And why does that matter from a precision medicine?
So what we do at UCLA is we'll take the biopsy, we'll decide that it looks like lung cancer, and let's say it's adenocarcinoma. That leads to a set of what we call reflex testing, because we've decided as a group that all those patients are going to get EGFR tests, as well as a panel of tests that we talked about, a lot of these mutations, EGFR, BRAF, KRAS, and then another type of abnormality can be tested with a group of tests called FISH tests. And so we look for ROS, ALK, RET, and MET. And those all happen. We also do PD-L1 testing to understand about immune therapy, and we have decided to do that for all of the cancers because it helps us understand them as we're picking through their options. But there are some decisions about only doing those in metastatic stage 4 cancer. That can be some of the questions that come up. We then look at the scans. We decide sometimes in a tumor board, is surgery possible? If not, is chemotherapy and radiation possible? As I said, in many cases, many patients, we first find out about the cancer when it's stage 4, and often we don't have surgery and chemotherapy and radiation, but we sometimes can still, in those circumstances, have a very aggressive approach in the right situation, where we might do surgery of a brain metastasis or surgery of a metastasis in the adrenal gland, chemotherapy, and then remove the lung cancer as well. So I think we're not in a world where everything is possible, but you do want to ask, is surgery the right situation? Could you explain to me why not? If one area is growing, could we radiate that? At UCLA, we've developed another technique that we call ablation. It's usually a needle ablation. A lot of hospitals do radiofrequency or RFA ablation, which is kind of like burning a tumor. We do a lot of cryotherapy, of freezing that tumor. But all of these techniques, surgery, radiation, all of them have just gotten better and better with faster and faster recoveries, to the point that we have very significant trouble sometimes saying, should a brain metastasis be treated with surgery or radiation? Because they both go so well in many times. So that's the good news. It's gotten more complicated. The world has gotten very complicated, but the number of options, the way to put it together, we think for better outcomes is really meaningful.
Can I ask you a question? So you talk about the complication, good news, bad news, right?
Yeah.
But you did mention a tumor board. Can you explain to the folks in the room and those watching what a tumor board is and how it is helpful, especially with some of these more
Sure.
complex
I can't finish a sentence without saying something that I should have explained better.
No, that's okay.
But so a tumor board is the way that particularly an academic institution, but not only, that many hospital systems will have to improve multidisciplinary care, just what Bonnie was talking about. You could imagine a situation where the oncologist is in their office and they see the patient, they write out their plan, then they go see the surgeon and the surgeon writes out their plan, but they might never even talk. The way what a tumor board does is it really gets actually everyone in the same room. You look at you talk about the patient. Some tumor boards, the patient comes, but not always. You talk about the patient's history, what brought them, any other serious illnesses. You look at the scans, you look at the biopsy from under the microscope, and then everyone gets an opportunity to say what they think the best approach would be. And a lot of times, lung cancer is not so cut and dry. Stage 3 lung cancer, you could have a whole weekend discussion about, a few number of cases because it gets complicated. There's many different ways to put it together, and we don't have research answers to tell us all the possible answers. So we use our best expertise and experience. But that's what a tumor board does, is it gets everyone together to talk about a specific patient situation. It's like getting 15 or 20 consults all at once.
I think it's really important when we're talking about precision medicine or personalized medicine, we're talking about tonight, it's quite often the thing we don't discuss, how important the role of a tumor board is in that process. It's not just, does it have, does the cancer have an EGFR mutation or an ALK mutation or a BRAF or whatever, but now what are we going to do about it, right?
Right, absolutely.
Yeah.
But it's also like many second opinions all in one day.
Yeah.
Yes, right.
Yeah.
So, always better to have more people looking at your particular cancer.
Absolutely. And all these rules that we used to have, there used to be a lot more, if someone had metastatic disease, we didn't do surgery. If someone had metastatic disease, we wouldn't do certain kinds of radiation. And a lot of those rules have been questioned, a lot because of the techniques getting better and better, the recovery getting better and better. And it's not that surgery is the right answer for everyone or radiation is the right answer for everyone, but it's important to ask and think about it.
Or is it some combination thereof?
Right,
right?
exactly.
Which we heard.
Yeah, those are the times that we really need the tumor board, when we're talking about putting all these different treatments together in a safe way, in a way that's careful, that we're watching as we go, change course if needed. Precisely.
Yeah. So we talked a little bit about some of the more common mutations and how they have drugs very specific to them, to whatever's driving that cancer. We talked a little bit about PD-1. Can you talk about tumor? So PD-1, as you guys know, and Dr. Goldman mentioned, is something that is measured for immunotherapy and options, right? But also tumor mutation burden, right?
Yeah.
So can you talk a little bit about that and how that's relevant?
Sure. So this is really kind of at the cutting edge, to the point that we haven't exactly decided how to incorporate it into our normal treatment decisions or our ongoing treatment decisions. These immune therapy drugs really took lung cancer by storm, if you will.
Or surprise.
Yeah, or surprise not that long ago. We knew that there were some cancers that the immune system might fight. Melanoma is the most classic one. But we actually really very specifically did not think that lung cancer was in that category. And the way that clinical trials work is that sometimes you treat patients as part of the trial that you weren't expecting to, or that weren't planned as part of the the final, type of patient that would be treated. And so some lung cancer patients were on these trials, and they did remarkably well. What I think now what we understand is, remember I talked about the exposures that can cause mutations, just like UV light can cause a lot of mutations, tobacco or other exposures can cause a lot of mutations. And the immune system is recognizing those mutations as abnormal and directing the T cells, the lymphocytes, the white cells, to kill those cancer cells. And when that works, that could prevent cancer at the very beginning. But it doesn't always work. And one of the ways it doesn't is that the cancer cells learn to turn off the immune system. And they have this turn-off switch that, all these names have acronyms. PD-L1 is a protein that the cancer cells can upregulate. They can put more of this protein on their cell surface. And when a white cell that's coming to kill them sees that PD-L1, that white cell dies. It doesn't do its function. And what we found was if we give one of these new drugs, or PD-1 or PD-L1 inhibitors, you can block either side of that pathway. That turn-off switch is gone. You've taken away the turn-off switch, or you've taken off the brakes. Sometimes people say that. And then once again, the white cell, the immune cell, can kill the cancer. Mm-hmm. It's about 20% of the time that we get these great responses. What makes immune therapy revolutionary is, one, it opened up. There was a period of time that we talked about, I think maybe the last time I was here or before, where the smokers were getting a little bit left behind, that all the development was for the non-smokers and these mutations. It turns out that the immune therapy is often helpful for the other group, the smokers. Right. So now we're actually, thankfully, in a place where it does seem that a significant improvement's happening for really almost all of our lung cancer patients. And I was, you were talking about, well, what does it mean and how do we use it? Is that?
The TMV.
Yeah, thank you very much.
You're welcome.
So PD-L1 is one way to pick immune therapy, pick patients that are going to get particular immune therapy benefit. Another approach has been to try to measure whether it's a high mutation tumor or not. And TMB stands for tumor mutation burden. And it's measured as mutations for every 1,000 letters that I was saying, for every 1,000 bases. And somewhere between 10 and 20 mutations per megabase is a meaningful, million bases. Somewhere between 10 and 20 mutations per million bases is the cutoff for what we think may predict for a good immune therapy benefit. It is not quite at the same level as PD-L1. It's not gotten an FDA approval. It's not clear that is going to be a next step forward, but it did open up a new understanding of what immune therapy is doing, and perhaps through some combinations of immune therapies, we could really maximize our benefit there. It does help us understand, though, which tumors are benefiting, which tumors are not. Perhaps by adding chemotherapy or other immune therapy drugs in combinations, we can expand the benefit beyond that 20% or so.
When do we get to the point, and I'm going to go back to the exon 20, 19, 14, et cetera, because that's a submutation in patients. And we already know that people that have the EGFR mutation, what was I going to say? Geez, Louise. And Tarceva works, but we also know with somebody that has like an exon 20, Tarceva does not work, right? So when are we going to get to the point, because I'm really anxious to live to see this day, where we start repurposing drugs from other cancers? People with the EGFR mutation, there aren't a lot in other cancers outside of lung, right?
Right.
But there's a lot of exon 20s outside of lung.
So we're getting better and better at that. So BRAF, someone brought up BRAF. So BRAF, the therapy for BRAF came directly from melanoma.
Right.
So BRAF in melanoma is about half of melanoma has BRAF mutations.
Right.
In lung cancer, it's more like 2%.
Right.
But so we took the knowledge we got from the BRAF melanoma, we got this combination of two drugs, and then it was brought into lung cancer therapy, and it is also a groundbreaking drug there. There are what's called HER2 amplifications or HER2 mutations that both of them that can be in breast cancer, stomach cancer, but also lung cancer.
Right.
And so we've learned about using those.
ROS1 ovarian.
Yes, right.
Quite a
ROS1
few
can
other
be a cross. RET can be a cross with thyroid cancer as well as lung cancer. So there are some times that we think, well, maybe we're not going to classify them as lung cancer, breast cancer, thyroid cancer. We're going to classify them as a RET cancer.
Exactly.
And what I've found is it's helpful to have as many different systems as possible because it doesn't always translate, but sometimes it does. It gives you an insight. It gives you a direction to look, and that has really accelerated care. You talked about how not that long ago it was maddening how little research was being done in lung cancer. And that's really turned on its head.
Oh, well, we've made statements like, more new drugs for lung cancer have been approved in the last 3 years than the last 5 decades. That's huge. That's huge. I remember the very first time I went to ASCO, and ASCO is coming up next week in Chicago. That is the big cancer meeting. And I remember going there the first time, and there was literally no one talking about lung cancer. It was breast and colon and prostate, nothing about lung, nothing. Now it's completely turned itself upside down, and everybody's talking about lung. And lung is starting to lead the way in how important precision and personalized medicine is.
Across cancers, We're going to have a living room like that really shortly. I want to step back to the immunotherapy for just a second, mainly because we get a lot of calls about immunotherapy.
I'm sure.
BMS and Merck and pharmaceutical companies are doing a really good job sort of communicating to the masses about this immunotherapy. And I think there's somewhat of a misconception for patients, for the layperson out there about what this is and what this means, that it is not for everyone. And I think one of the ways it was explained before, and you and I have talked about this, your immune system is set up to recognize things that do not belong in your body and get rid of it, right? Well, cancer is real sneaky, right? And it hides easily. And somebody said it was sort of similar to a woman when she's pregnant, right? That baby is not supposed to be there. Those cells are not all, in my case, mine. They were my husband's as well, right? So my body should have recognized it and gotten rid of it. But there's this like cloak, right, over this baby, protecting it from the immune system getting rid of it. And cancer works in a very similar way, which is why this PD-1 and the PD-L1 were such a breakthrough and so exciting when it came out, because people have been trying to turn the immune system on for a lot of years, right?
I thought you were going to say sneaky like a woman, and then I'm glad you didn't say that. I wasn't sure where you were going. But
I might next time, now that you said that.
I have to throw you a kudo, though, because I, for one, know that you were probably one of the very first physicians that offered an immune therapy drug to their patient who really had no other.
It really was. I mean, it's hard to realize what a change we've seen in this. I really do mean, just as you said, not one of these solutions is the right thing for everyone, but we are very much at a place now where we have a new revolutionary approach for, I would say, every patient, and that has made real changes. We still have so much work to do, but that has made real changes. And I think that the immune therapy is in some ways the hot new thing. There's a lot of ad money behind it and everything like that. It does have a role for many patients at some point. And of course, you should ask your doctors about it, but it may not be the best first therapy.
First therapy.
And it's heartbreaking to see these direct-to-market commercials.
I think sometimes
I would agree and I would disagree. Sorry, which is so weird.
Let me finish my sentence. Let me finish my sentence, and you can disagree all you want. That's great. I think in my own mind, being a patient, that it's heartbreaking because it works for a very small number of, at this point in time. Hopefully someday it's going to work for a lot more when we identify all those other submarkers that are out there that we don't know about just yet. But I mean, I can't imagine, the heartbreak a patient hears when they find out that they're not a candidate for it.
But
this new,
and this is where I'm going to disagree, because I think the problem is not in the communication to the patients, because I think anytime we're communicating with patients, whether it's us or pharmaceutical companies or the physicians or some combination of thereof about treatment options for your disease, it's a good thing because people are listening, they're paying attention to lung cancer. 13 years ago, to your point, nobody was talking about lung cancer, so at least people were talking about it, right? Oh man, and now I lost my train of thought. Oh, I hate it when that happens. Barb, you have a question, that's perfect timing. Asking the question.
They go into their doctor, and you talked about earlier a lot of the physicians who, they cannot be experts on everything. But if they say, well, can I take this Keytruda? At least it will force the physician to go and do that research if they don't know.
Especially,
and if not, then maybe they see what the other options are. So
especially
I think it's pushing to have the conversation at a deeper level.
It is, and it's also bringing options to other, because a lot of the discovery has happened fast and furiously in the non-small cell adenocarcinoma patient, right? You said that early on. Now we're seeing some of this crossover into squamous. We're seeing it crossover into small cell. So it's bringing options to the table, especially in small cell, that haven't been there, no changes in 40, 50 years in how to treat the small cell patient. Kim, did you want to say something?
Two open-ended questions was advances in squamous and advances in small cell. Discuss.
Yeah, absolutely. So, what I love is that over the years, we're not leaving behind groups. Squamous cell has had some real advances, first with immune therapy, but increasingly it's recognized as a group of patients that need more and more research. There are different kinds of targeted medication approaches, and some of them are using antibodies. Antibodies are developed in the lab to recognize a protein, and increasingly you can attach a toxin, usually a chemotherapy, to that antibody, and it will just go to the cancer cell. So we're doing research. MET can be increased not just in adenocarcinoma, but also in squamous cells. So we have a trial of using a MET chemo combination antibody. It's called an antibody drug conjugate, meaning you put them together to bring chemo just to the squamous cell cancer cell and minimize other side effects, because there's not as much chemo running around to other parts of the body. Some of these mutations that we've talked about can also occur in squamous cell, so that is an important thing to be aware of. Particularly in a non-smoker with squamous cell, they should definitely be tested for those mutations. Small cell, as you're saying, was really a very, from the development of our understanding, very interesting. It's one of the first cancers that was found to be chemo responsive, and people were kind of predicting it would be cured. But what we learned was that when it comes back much more resistant, and often much more quickly than you would like. From that initial understanding, we've had almost no development in decades. And then just in the past couple of years, we've used immune therapy. We've also, either as after chemo or just in the past year, using it with chemotherapy to improve responses and length of responses. We have a trial going on that we're just putting our first patients on right now of combinations of a low-dose chemotherapy with a DNA repair blocking drug. And these kind of things are happening just more and more. This is a trial that I developed just myself, but companies are also working on them. As I was saying, some of the challenges is that pattern of a response and then resistance, response and then resistance. And maybe it's through combinations that we'll be able to get, just like we learned to treat tuberculosis or HIV. There's an obvious appeal to the idea of putting several drugs together. The cancer cells won't be able to become resistant. It's been challenging so far, but we're learning better and better about what drugs might combine safely. We'd had trouble before of these combinations having more side effects than expected. But we have newer ones. We're hoping to open one in the next few months for EGFR patients, putting together combinations there. So I think the squamous cell and the small cell are coming along, thankfully.
So go ahead.
Do you think because we're doubling up on therapies, because we didn't used to do that, they just got one or this one or that one, that's probably the reason for people living longer with
I think I think it's many factors. So screening is really actually a known benefit. Each of the different techniques being better, so we can radiate. Brain metastases used to be very, very challenging, and patients would get whole brain radiation, and that, not for everyone, but for some people, led to some real challenges, especially if they lived a long time. They would get side effects. So targeted radiation was able to get cancer under control without the same side effects. That's led to people living better. And then these new classes of drugs, sometimes we have a lot to learn about how to put them together. We sometimes run into a situation where we had several lines of therapy, then we put them all together, and now we don't know what to do next. So there are steps forward and then kind of a re-understanding that has to happen.
So one of the things I think we're talking about now, which was sort of you segued into my next question before I even asked it, was does this whole precision medicine concept stop after original diagnosis, or does it move on past that? And you mentioned, the response, resistance, and I think in listening to people in the room and folks I'm sure online and people we certainly talk to every day, we talk about scanxiety and anxious about switching scanning schedules and what that might look like, and so patients wonder, I want to put my head on the table and know that there's a plan B in my back pocket for if and when I need it. And I think that's what we're talking about. And can you talk a little bit about how precision medicine plays a role in that sort of next phase upon resistance, and how clinical trials can play a role in that?
Sure. So a lot of people brought up T790M, which is, I think, our best example of this. EGFR mutations, we said, are common, and especially on drugs like Tarceva, about half the time you would get resistance because of what's called a secondary mutation, a new mutation called T790M. And that was considered untreatable for many years because all of the drugs weren't good at it. Some of the at treating it, some of the drugs thought they might be, but then they ended up in patients to not be particularly effective. Until we got Tagrisso. We were involved in several trials. There was about 5 or 6 drugs all at the same time trying to be developed to treat T790M. And in this case, there was one drug that was clearly the best, Tagrisso, that was effective, well tolerated, good, active in the brain. And so just as you said, you identify the EGFR mutation at the beginning, you started a drug, you developed a resistance, and then you identified what that resistance was from, and that put you onto a new drug. And so now we know that Tagrisso can stop working because of a tertiary mutation, a third mutation in C797S. And so now there are C797S drugs that are being developed. And so it's interesting. You learn a lot. It is also a little bit overwhelming at times to know that that cancer can be so tricky and develop resistance. And it may be that that's why the combinations are what is going to get us out of that pattern, but we're still learning about it and along the way getting better and better drugs. We didn't talk too much about ALK, but ALK is another place where, as I say, we've had several different developments of drugs, generations of drugs, and some of them there's many more different types of resistance mutations with ALK. And some of these new drugs work with some mutations, but not with others. And so we use those mutations, increasingly found in a blood test rather than a new biopsy, to tell the doctor and the patient, this is the right drug for you to go on. And, rather than just going down the line, being able to use a precision medicine approach of what's the right drug before we start, to be able to get results certainly within a month, but ideally within 2 weeks, and maybe even faster, is what's going to keep patients healthy. The reason why we get scans is to find out if something's not going the way we want before someone feels bad, so that then we can keep them feeling well and get onto the right treatment.
I think, Kim, you have some questions online.
Oh, yeah.
Segues into the testing. And it is, what are your thoughts on multiple testing to ensure avoiding false positives and or making sure testing covers both breadth and depth of all genes and or possibility of not getting a great tissue sample?
So each test has its goods and its bads. I think we scientifically talk about tests being sensitive and specific. Sensitive means how good is it at finding the abnormality, and specific meaning if you find an abnormality, how sure are you that it's really there? Most of our tests have gotten incredibly specific, meaning that if you have a positive test, be it from the blood, be it from the bronchoscopy specimen or CT-guided biopsy, or from a surgery 3 years ago, if you find one of these mutations, we think it is dependable. We think that is information that you can depend on. And if you got another test that didn't show it, we would think it was the other test missed it, not that the first test was wrong. So we think most of these mutation tests you can depend on if you find the mutation. If you don't find the mutation, then you have another set of problems should you do another biopsy to try to identify it. And the way that comes up most frequently these days is what we usually do is we do a blood test. If that doesn't find a resistance mutation, are we then going to go ahead with a tumor biopsy? And it really depends on the situation. It depends on how easy is it to biopsy. Do we have other options? How quickly is the cancer growing? Do we think that chemotherapy or our other backup options will be effective? But that's what we do. That's why we think about this. That's why we talk in tumor boards, so that we're ready to answer these questions when they come up. Mm-hmm. I can't just say that every patient should always get a biopsy. It depends on the situation, but it's always appropriate to ask. If this test came up negative, should we or do we need to test again in another way?
When do you think we'll be testing in the blood to find progression before it shows up on a CT scan?
It's such an interesting question. There's all these, what we would want to know is that by testing in the blood, starting a new treatment sooner, you're in the end getting to a patient generally feeling better over time and living longer. And that's actually harder to prove than you might expect. It is possible that finding a resistance earlier and getting on a new drug just means you cycle through the drugs faster. It's possible. Another way we're thinking about using this is if someone has surgery, there's actually pretty good evidence now that you might be able to look in the blood a couple weeks later and figure out whether they have a good chance of being cured or not.
Right.
It's not, we say, it's not ready for prime time. It is not ready for us to base such important decisions on, because a lot of these trials are in a relatively small number of patients, sometimes even 20 patients. We think, lung cancer is so common, unfortunately, decisions we make are going to be affecting hundreds of thousands of people. And so we think we need a pretty strong level of evidence. But I think that may be actually the next step of blood testing is, can we predict the patients at high risk of recurrence? Can we then try something more aggressive, like putting immune therapy in early or a targeted therapy in early, or multiple therapies together, because we know this is a chance perhaps to cure, and we should be extra aggressive.
And to keep it from metastasizing.
Yes,
Well, and I think that was, Joanne, what you were saying. You're in this study, looking for progression in the blood. During one of your blood draws, it appeared based on this test that there was, and you had been on Tarceva, right? They went back in to see if she had developed T790M, and she had.
Yes.
So it was a tool in this case
Yes.
to push her towards, or her physician towards, being able to make an informed decision.
Absolutely, absolutely. And in this case, sorry, go ahead.
The question that you brought up, which is unknown, will I just have the same length using that drug and before I get another resistance as if I had started it 2 months later, or am I gaining 2 months?
Mm-hmm.
This
Well,
is the unknown.
it all goes to early detection. The sooner you find anything, the better, because the information is powerful.
Yes, yes.
About
It's
next steps.
clearly true, especially true in the early stages,
Mm-hmm.
and why screening is so important, why it's so good to have programs to promote screening. Lung cancer screening has not been as commonly done.
4% of the population are going in for a scan.
Yeah, it's remarkable. I mean, it's as good or it's better screening than some other things that are commonly done, and so we should do everything we can to increase it.
I think with the blood test, sorry, Joanne, just want to make one comment. With the blood test, one of the things that's most exciting, and I don't know if a lot of you know, is when this first started becoming a thing that people were looking at, whether they were looking for progression or can we find some of these mutations in the blood, everybody was like, it is going to take 20 years for them to get these tests to where they need to be. And now, here we are, just a handful of years later, and it's happening so fast. And I think that's what's one of the most exciting things about all of these great, potential options for patients, especially for lung cancer patients from a diagnostic perspective. We're pulling tissue from, a tumor in your lung is a big deal.
It's amazing. So we may be in a situation where. Sorry, I did that. We may be in a situation where we've just gotten the biopsy, or even we've just gotten the scan and we see that it's lung cancer.
Mm-hmm.
We're doing the circulating tumor DNA from the blood test, and we get the mutation in the diagnosis. We still need to do a tumor biopsy at this point. But within a week, we might be ready to go with treatment. With a precision targeted therapy.
I think that's one of the most important things you just said for when we're talking about this blood biopsy stage. The blood biopsies, in a couple of instances, but as a whole, for diagnostic purposes up front, is not the gold standard. It's a start, but if it's negative, it's still not approved, so you can't trust a negative. There may still be something there, which is what Dr. Goldman's saying.
They are approved, but they're not.
That's what I said, in a couple of like T790 and yeah.
But they're, to go back to the sensitive and specific, and we're really, you really have to go to medical school to get when you get a cancer diagnosis. Unfortunately, it's so complicated. But
that's how this all started.
Yes, exactly.
There was a reason for it.
Right. There's so much to know, but the sensitivity of these blood tests is not 100%, and so we know that maybe we're missing 20% of the mutations, maybe 10%, and so you still need to look at the tumor at times.
Is there truth in the fact that when we do a tissue biopsy, we need to get into the core to be positive that it's a real accurate test? And is that true for the blood as well?
So there are these different benefits of blood and tumor, and actually we did a study for the T790M purpose, where we also looked in urine, and you look at urine, blood, and tumor, and you see each of the techniques misses some of them, and putting them all together, blood and tumor is what we've now come up with, is the best way to catch all of them. The biopsy needle has to be in the right place where there's tumor, and you're only going to learn about that one part. The blood, you can think of it as, we sometimes call it a reservoir of mutations. What's happening is that the cancer cells through the body when they die or when they leak DNA, there's DNA in our blood all the time. You can catch that at a 1% level in the blood, and with these very sensitive techniques. So you are having some ability to get to kind of question or survey cancer throughout the body. That's one of the appeals of it, is that you may get with a single snapshot a better picture of the whole body.
Sorry, I think Joanne has a
Yeah.
question. I know we have one online.
Backing up a little bit, but how is tumor burden mentioned? You talked about that as becoming maybe a measure of appropriateness of immune therapy, but
Yeah.
how is that measured?
So it was originally measured by getting a patient's their whole DNA, and then we actually went to something called whole exome sequencing, and that's trying to take all the important parts of your DNA, all the DNA that's making proteins. And you asked me a long time ago about exomes, and exons, and so that gets a little out of the. I can maybe get back to that if we want to, but so we initially looked at a whole big portion of the DNA and just counted up the mutations. We learned that we could use some of these more targeted techniques, looking at 100 or a few hundred genes, and using that as a, just like with the census, where you don't ask everyone in the country, you ask a portion of them, and then you extrapolate from those genes what's the expected mutation rate for the whole tumor. And that's how a lot of these studies have been done, looking at specific immune therapy combinations. And it's clear that a high tumor mutation burden tumor has a higher response rate than a lower tumor mutation burden to immune therapy. But exactly what that's predicting as far as survival benefits isn't clear yet.
Kim?
Okay, I have to hold my hand out.
Here are my glasses.
For RET mutation, they're on Loxo 292, and it's keeping the cancer in control, but it looks like the cancer has become resistant as there's a small nodule on the spleen. Is surgery advisable, or once a new biopsy is done with the impact test, should we look into a new target therapy? And then another question earlier had said, could you mix therapies?
So that's a very complicated question. Very complicated question. So, I wrote down all the mutations just so that we would talk about all of them, and we really, I don't think we talked too much about KRAS, actually the most common, about 20%. But after KRAS, EGFR, and ALK, there's many more that are in the 1% to 2% range, and RET is one of these 1% to 2% range slices of the pie. And there were about 4 drugs that were designed for other purposes but were reasonable RET inhibitors in the lab. We first tried those with these RET cancers, and we had somewhere between 20 and 40% of cancers responding, but for not that long. It was disappointing. It wasn't clear, is this going to be a success story or not? And then thankfully two companies developed very good RET inhibitors, and one of the most promising is this Loxo 292, and you really see the power of chemical engineers, of people making drugs and increasingly able to understand, well, if I tweak this, it's going to last longer in the blood, and it's going to be more effective against this mutation and absorb better through the stomach. Things like that, to make better and better drugs, or be able to treat a cancer in the brain. So this is really one of these late generation drugs that really shows the power of modern medicine and science. We're at the point that I wouldn't say we have a clear understanding of what causes resistance to Loxo 292. We would say in general that if you have an effective drug that's being well tolerated, especially after a while, one area becomes resistant. If it's treatable with radiation or ablation, that's often an appropriate option. We as doctors have to acknowledge that we don't always have strong evidence that is going to lead to better long-term outcomes than if not. But we have some evidence, and it certainly makes some common sense, that if you can safely treat a growing area, that's a good thing to do. Targeted radiation in many situations, very targeted to small areas, has often very little side effects. The spleen is a little bit unusual and a little bit more complicated, and I would have to ask a radiation doctor, is the short answer. But I think that some approach to a growing area is reasonable. In general, if we do that and we can stay on the same treatment, we usually think we should do that. We might get 3 months, we might get 6 months, or we might get 12 months before we would have to make another change. If a drug's been well tolerated, it's nice to get to stay on it. But we don't know too much about, there's another company developing a RET inhibitor, there's all those other RET inhibitors. We don't know too much about switching from one to another. We do know switching from the old drugs to the new drugs, you do better. But between the new drugs, we really don't know too much.
I just want to point out, because we're talking about it, and I know you have a plane to catch, and we're kind of running low on time. But no, I'm gonna let you ask that. What we're talking about right now, there is a whole other living room in the archive on, and it's called oligoprogressive or oligometastatic disease, where you're just targeting a certain portion of the cancer that seems to be progressing, while the rest of it seems to be sort of maintaining its space. So, if anybody needs more information on that, just give us a call, and we can talk about it. Larry, go.
Just one quick question, and I may be asking Bonnie's question again, but what's current thinking about if you see mutation in the blood, but not in the tumor? Could that, because of maybe tumor heterogeneity, and is in that case the blood more reliable?
That's exactly it.
Big word.
Yeah, exactly. Yeah, you're ready to speak at one of our conferences. We exactly think it's due to tumor heterogeneity. That means that tumor is not exactly the same everywhere, and that certainly makes sense, particularly with a resistance mutation. Not every cell through the body is going to develop that resistance mutation at the same time. So you might just, because of where the needle goes or the specific tumor, not catch a resistance mutation that might be in the blood. Conversely, not all tumor is releasing DNA into the blood. So there is a role for each. If biopsies weren't challenging to schedule with some possible risks, we would do both in everyone. But what we've come up about is that in many cases, a blood test is a good first step. And then if you really want to know if there's a particular reason why this will lead to a specific decision and specific option, then a biopsy increasingly can be done quite safely.
If that biopsy is negative with a positive blood, where do you go from there?
We would in general, I would say across the board, treat any positive test as a real positive. So we would base treatment based on that finding of a mutation.
I just have a quick question about progression. And from what I'm hearing, progression is when your body becomes resistant, or the tumors become resistant from the.
Yeah, it's such a funny word. Progression sounds good to some people, but yes, we've in medicine used that word to mean that the cancer is growing, and some patients are familiar with that.
Responding to your current treatment. So is it because you're building up an immunity to the treatment, and so they have to just give you a new drug, or should they rebiopsy to see if the mutation is actually changing, and they should actually target with a different drug altogether?
So it really depends on the situation and the mutation and what we know about it. The best is if there's going back to ALK, one of the first line drugs that we use is called alectinib. And there are probably 15 or so different resistance mutations that we know of. And one of those mutations tells us to switch to brigatinib. If it's another mutation, then we might use another type of therapy, lorlatinib, for example. So in that situation, we definitely would like to do some sort of biopsy. Some people call the blood test a liquid biopsy or a tumor biopsy to see if we can identify which drug to use. There are other situations where we don't have as clear knowledge about what we're going to do with information. And particularly when we're thinking about a biopsy, which again takes some time and has some risks, I like to know that I'm doing it for a particular reason, that some results will tell me to do a specific therapy. And there are some cases where we don't know as much about the resistance mechanisms, where you might say, well, it's worthwhile to do a liquid biopsy with lower risk, but not worthwhile to do the tumor biopsy, depending on the situation and the options. Is that clear? There's not a one-size-fits-all answer to
Wayne, if you come up here and grab the mic, I'm gonna sadly have to ask that this be the last
I have
question.
a quick question.
Go ahead, yeah.
What's your opinion on trying a different immunotherapy drug if someone hasn't responded to one previously?
That's a very good question. So there are some ways that different drugs in the class are different, and mostly that's these pills, that what we call small molecule inhibitors or TKIs. These are all words that doctors use, but these are the mutation blockers, if you will. Immune therapies are antibodies, and for the most part, we have almost no information that switching from one to another is going to cause a benefit. If the cancer has become resistant to one of our immune therapies, it is exceedingly likely to be resistant to another one. And also, if you get a side effect to one of the immune therapies, that side effect is very likely to also occur on another immune therapy. And that is true of the approved immune therapy drugs. There's 5 different PD-1 or PD-L1 inhibitors, and they're all very similar in most ways. There's another type of immune therapy called a CTLA-4 inhibitor, ipilimumab, which is not approved in lung cancer but has been used in trials and is approved, or at least has some recommendations in small cell. That's a different kind of immune therapy. There are some times that adding it could be a reasonable choice, but for the most part, switching from I can use names, right? So switching from Keytruda to Opdivo is unlikely to be a good choice. Better to, what we would love to do is to learn more about appropriate therapy and look at clinical trials, for example, of newer kinds of immune therapy. All of these benefits we've talked about really came from an understanding of just 2 proteins and how they interacted. We know that the immune interaction is very complicated with more than 10, probably more than 20 proteins on each side of the tumor cell and the white cell that are interacting in different ways to either promote or block an anti-cancer response. And so it certainly makes sense that we should be able to affect that interaction in a way that could help patients. It's been challenging, and we haven't had a breakthrough success in those new areas, but we hope through research to get there. The other kind, just for a second, the other kinds of immune therapies we're looking at are vaccines, or as I said, adding it with chemotherapy or radiation to try to jumpstart an immune response.
Great. So I always hate this at the end of the meeting, because it's usually when most of the questions start all creeping up and coming along. But if anybody has anything that they did not get to ask, please let us know, and we'll make sure to get the questions to Dr. Goldman and those.
Yeah, I didn't answer Bonnie's question. That's not the way to get invited back.
Know, that's right. You will be invited back. A couple of things I hope people took away is, it's for me, over a decade ago, we used to go to these meetings and look at the research and what was happening and the waterfall, charts and all this stuff. And we used to be like, man, they are throwing pasta at the wall to see what sticks, right? And we have come such a long, long way. And personalized medicine and this approach is affecting outcomes really across the board on most levels. If you're including immunotherapy in that, and cancer's not exciting, any kind of cancer, right? But it's an exciting time when we're talking about the research that's happening, the outcomes that we're seeing, and how it's crossing diseases. So huge thank you to Dr. Goldman for coming up and talking to us tonight. Everybody can clap now. About precision medicine, because I think it's such an important thing to continue to talk about.
You could have sat here for more hours.
Yeah.
We could have said.
Yeah, thank you so much for your question.
As soon as he said just a few more seconds, I'm like, it's your plane to get
Right.
No. I'm going to do a little bit of housekeeping, as always. Up next is the June 18th living room here in San Carlos, where we will be talking about how lung cancer and lung cancer research is having a pretty profound effect on how other cancers are looking at their disease and how they're treating.
I was on a call today with Gardens, and for a thing we're doing at ASCO, and we had a doctor from MD Anderson, and we had a doctor that specializes in colon. And
is he down south? Is that what?
Right. No, but I just we're starting to intermingle the diseases and finding out, well, what's working over here and what's working over there, and really getting outside this place.
I just wanted to let Kim know, Kim's from Tennessee, and just when we say down south here, we're talking about LA. That's
we're
what
not talking about.
That's what we mean when we say down south up here.
That's the south.
Yeah.
Down south.
Yeah. You're welcome. I just didn't want you to be confused. I should probably tell Angela that too. Okay, June 10th, our golf tournament. This is not for anybody online unless you are local here and or you want to fly in for it at Green Hills Country Club in Millbrae. I think we still have some spots available. June 22nd, we have a GoTo 5K, GoTo Foundation for Lung Cancer 5K in Portland, Oregon. So if anybody's signed in from Portland,
anybody moving,
participate in that, please don't have. I don't know. Dave and Barb have friends in Chicago, so they went out there for the 5K out there.
Exactly.
Right? And I know.
Exactly.
Don Stranathan, who's a patient who a lot of you know in the room, he could not be here tonight, but I want to give a shout out to this Celebrating Survivorship event that he is having also on June 22nd in Winters, California, which is just up the road in the wine country here. It's on a 55-acre ranch. They'll have live music by the British Infections band. I hate it. I hate British Infections. I love their music. They've played at our 5K. The name gives me anxiety. Anyway. Food, drinks, bocce ball, cornhole, horseshoes, and more. It's a family-friendly event, and
now,
everyone
those
is
are
welcome.
sports I can participate in.
Yeah, right? Cornhole in the wine country.
Ball. I love
wine,
bocce
ball. Huge thank you to, of course, all of our patients and caregivers in the room, those online watching, those who will come back and watch us post live. You again, I say it every month, every meeting. I mean it every month, every meeting. You are why we do this. So thank you for showing up. Thank you for sharing your stories. It's so important. And we are so grateful that you give this gift to those who will come back and watch remotely. So thank you. Peninsula Television, once again, every month for coming in here, setting all of this up. They're waving. Setting all of this up. I also say this every month. If you haven't seen the War Room, just poke your head in and say hi to the guys sitting back there with all that equipment.
There's a TV station back there.
Because there is a TV station in the storage room, and they do it every single month. So thanks to you guys. The Office Bar and Grill for generously donating the food every month. Thank you to them. Like I always tell everybody, the third Tuesday of the month is pasta night, so do not have pasta or plan pasta in your week because there is a ton of it. I want to give a huge shout out to our supporters who, without their support and their belief in what we are able to bring through this program, to all of you, we would not be able to do this. So Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Celgene, Dignity Health, Genentech, Lilly, Merck, Novartis, Takeda, and Tesaro. Thank you. I want to give a special thank you to Bayer for supporting a 3-part series, Precision Medicine in the Treatment of Lung Cancer. Does my tumor have a biomarker? Really understanding pathology and what that means, and that it's never too late to test, which we didn't get to tonight. So thank you to them. Thank you to Sally. I saw the dessert come walking in. Kim brought it in. Thank you, Kim, for getting the living room set up every month. Sally brings dessert here every month. Usually if Ron is here, they war over who brought the better dessert. But Ron's
The better
not here
coffee cake.
tonight. Yeah. That's the crunch cake. They will drive all the way up to the city, to San Francisco, to get special coffee crunch cake to bring here. Anyway, Sally, thank you, thank you. Please come get dessert, everyone. It's been great. So until next time, have a great evening.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.